Hello, my name is Eugenio Mercuri. I'm a professor of pediatric neurology at the Policlinico Universitario Agostino Gemelli, Università Cattolica del Sacro Cuore in Rome, Italy. It's my pleasure today to welcome you to the discussion of consideration for the selection of disease-modifying treatments in SMA, a case-based discussion. I'm here with Professor Nathalie Goemens from the University of Leuven in Belgium, and Professor Tim Hagenacker from the Essen University Hospital, Essen in Germany. And today we will discuss three cases, and the first one will be the treatment selection for a 3-month-old infant. The second will be the treatment selection for a 3-year-old child. And the third one will be the treatment selection for an 18-year-old young adult. Individuals who do not have SMA, who have a normal SMN1 gene, will have a normal quote of SMN protein that is mainly expressed by the SMN1 gene. There is also a little component that comes from another gene, which is called SMN2 copies, that can be present with a variable number of copies. Individuals who have a normal SMN1 gene have normal levels of SMN protein and the normal neuromuscular development. In spinal muscular atrophy, there is a mutation, which is often a deletion in the SMN1 gene, and therefore the majority of the protein that is normally produced by the SMN1 gene is not produced. Therefore, we can only rely on the small quote that is produced by the SMN2 copies. And because the SMN2 copies, the number of SMN2 copies can be variable, the phenotypes reflect the number of SMN2 copies, because each of the SMN2 copies can produce a small amount of SMN protein, and therefore the more copies we have, more protein we will have. And this results in the difference in the variability in the phenotypes. There are some approved treatments for SMA, and I will briefly discuss the mechanism of action of the 3 available approved treatments. The first case is having gene therapy. We know that when there is a mutation in the SMN1 gene, it's possible to replace the gene with the mutation with another gene who is able to produce some SMN protein. Therefore, we go to the root of the problem by replacing the gene with the mutations with another gene that is carried by a viral vector. And this results in increased SMN protein and an improvement in motor function. Another mechanism is to have an effect not on SMN1 gene, but on SMN2 gene. You may remember that the SMN2 gene is able to produce a small amount of SMN protein because the majority of the protein normally produced by the SMN2 gene is a non-functional protein. A different mechanism of action is to intervene on the SMN2 gene, improving the splicing and therefore improving the quota of SMN protein that is produced by each copy of SMN2. Therefore, an increase of the SMN protein by improving the splicing produce an improved motor function. The 3 approved treatments have different labels and different modalities of administration. The first one to be approved, the antisense oligonucleotide, is available for all patients with 5q SMA and is administered through an intrathecal bolus injection with 4 loading doses and a maintenance dose every 4 months. The second one, the gene therapy that has been approved in May 2020, is only for patients between 2.6 and 21 kilograms with a diagnosis of type 1 SMA and the number of SMN2 copies of 3 or less. The administration of gene therapy is a single dose intravenous infusion. The third is risdiplam, is a small molecule, and this has been approved for patients of at least 2 months of age with a clinical diagnosis of 5q SMA, type 1 to 3, and 1 to 4 SMN2 copies. The administration here is oral, is once a day after a meal, and usually at the same time each day. These are the general indication, and there are, of course, some regional variation in the indications depending on the approval in the individual countries. There are some special considerations for each of the three treatments. For nusinersen, there are some common adverse events that have been reported, and these are mainly procedure-related, consisting in headache, vomiting, or back pain. There are also some less common risks associated with the lumbar puncture that may require sedation, potential exposure to fluoroscopy, and it's worth mentioning that in patients who have a very severe scoliosis or with scoliosis surgery, there might be some difficulties. Some other risks associated with administering antisense oligonucleotides are related to thrombocytopenias or coagulation abnormalities and renal toxicity, even if these have been reported very rarely with nusinersen. At the same time, also there have been very few reports of hydrocephalus. With gene therapy, there are also some adverse events which are quite common at the time of dosing, like pyrexia or vomiting, and special attention is paid to thrombocytopenia or hepatotoxicity, especially with hepatic enzyme increase that should be treated with steroids when present. With gene therapy, it's also suggested that patients should not only have a determination of the AAV9 antibody, of course, that have to be negative in order to proceed with dosing, but also to have an assessment of liver function, creatine, blood count, and troponin to make sure there are no pre-existing conditions of involvement of these organs. There is also discussion of whether an immunomodulatory regimen is required if the patient is AAV9 positive. For the third drug, for the small molecule risdiplam, there are also some common adverse events like diarrhea, nausea, or mouth ulcers, rash, headache, and pyrexia that are relatively common at the time of dosing. And there are some potential risks that have not been reported, like retinal toxicity, embryofetal toxicity, and male fertility effects. Now, we will start with the description of the three cases, and we will start with the youngest, who is an infant who is less than 6 months old. This child is a 3-month-old infant girl who has hypotonia and clinical signs of SMA. Genetics testing confirms that she has SMA with 2 copies of the SMN2 gene. So, questions for this case are: which treatment options can be considered for this patient? Professor Gomez, Natalie, would you like to address this question?
Yes, thank you for the question. And I think, as you have discussed previously, for this child, we should consider that we are in a luxury position, because actually this child would fit the indications of the 3 treatments that have been approved by the EMA for the treatment of 5q SMA. As this little child has this disease, has probably a weight below the 21st kilogram, and a copy number that's also applicable for this treatment indication. Saying this, however, and I think this will be the next question, there are obviously considerations why one should treat one or the other. And just one thing to mention before we go to this discussion, I think for this kind of situation, we are in an emergency. I think this is an emergency situation. When we see this little child, we really want to start a treatment as soon as possible in order to keep the loss of motor neurons as small as possible. And this is probably one of the major factors that would influence our decision.
Thank you, Natalie. And you have already introduced one of the key factors influencing the choice, that is speed of action, because as you said, it's very, very important to intervene as early as possible. I think it's appropriate to discuss also which are the other key factors that influence our choice as clinicians between having three different options. And also, at the time when we discussed the treatment options that are not always decided by the doctor, but they are decided together with the family, which are the indications, which are the informations that is important to cover with the parents or the carers of the child?
Yeah, so if I can go, definitely when we discuss this treatment, one of the first things is risk benefit of all the different options that we have, and being honest about the safety aspects of each of these treatment. As you know, for instance, for gene therapy, there are not always there, but there might be quite serious adverse events that have to be taken into consideration. On the other hand, the nusinersen approach with the limitations due to the route of administration are also important. And finally, like for risdiplam, which seems like an easy way to administer, we should bear in mind that these are very small children, and that even giving a regular oral application of a treatment is not always easy. And finally, I think the very important is managing of the expectations for both of all these treatments, and this will obviously depend on the timing of the treatment, when we can install the treatment for spinal muscular atrophy. And if there are already symptoms, we have to be honest with the parents what we may expect with different types of treatment. But I will leave others for the discussion as well.
Yes, and I think what is also important is that we now have many data available, because we don't only have the results from the clinical trials, but there are several papers reporting real-world efficacy and safety. So we are in a very privileged position to offer a lot of information on different aspects, also of efficacy, depending on the condition of the child, how severely affected is the child, the age, the number of SMN2 copies, and so on. So I think for the time being, we are in a position that for at least two of the three drugs, there are also real-world data available that help a lot the family to taking a decision. And you have already touched the possible risk and benefit ratio of the potential treatment options. How do you counsel parents regarding possible outcomes? How do you set up their expectations? Because what we have learned from both clinical trials, but especially from real-world data, where there were no exclusion criteria as in the trial, we do know that there is some variability in the possible responses. So how do you counsel parents regarding possible outcomes?
I think it's important to emphasize that there is no clear evidence that one drug is absolutely superior to the others. Yeah. So I think all treatment options are available in this case. And I think it's important to give that message also to the parents. So we can do either one way, or we can possibly, before we finally decide, because you already mentioned that start as early as possible is important. If, for example, parents think about gene replacement therapy, it may be an option to bridge the time before initiating such a treatment, to bridge the time with either nusinersen or risdiplam, depending on individual situations. So there are some aspects that have to be considered first, like the already mentioned titers against the AAV9 virus, and so on, and parents, and as well as the doctor, have to assess the burden of treatment. For example, for nusinersen in such small infants, you have the problem or the risk of general anesthesia you will need for a proper administration of nusinersen. But as already mentioned by Natalie, on the other hand, it is not that easy to guarantee that an oral liquid solution is really administered completely, and there may be some handling problems. What if the baby spit the drug out? How many? If there is vomiting, the time between vomiting and the time, how many time has passed for the last administration? But I think all these aspects have to be considered in some kind of shared decision making. But it is absolutely essential to hand that a little bit over to the parents and to give them the best information we have. On the one hand, the information from the clinical trials, as you already mentioned, regarding safety and efficacy, and on the other hand, the practical aspect, what it really means to perform intrathecal administration, because that may be accompanied with anxious thoughts about an LP and so on. And on the other hand, the risk and benefit of the gene replacement therapy like hepatotoxicity and the risk that comes with the transient prednisolone administration.
And I think there might be one aspect that we haven't discussed yet about the gene therapies that we have to disclose also to the parents, that this is a once in a lifetime shot. And I think, well, so far, unless we will have further modalities to reduce immunological reactions if we reiterate the gene therapy, but so far it's a one in a lifetime therapy, and we are not sure about whether this is a lifelong treatment. So far we are positive, but we have to disclose this also to the parents. And in many countries, there is also not the option to give both so far. So if we give gene therapy, we have to discuss also to the parents that other therapies might not be available for their child in the future.
Yes, I think we now have a better indication on what to discuss with the parents. If we want to have a short summary of what has been said, is that we have enough data to provide about safety. All three drugs are relatively safe with relatively minor side effects or minor common side effects, let's say. And also the matter of expectation is very important, because none of the three drugs has the same effect in all the children, and they all show some variability depending on the age and the severity when the severity of the phenotype when the drug is started. I think we now have all this information, and I think we are in a much better position to manage expectations and to provide correct information. And the only one we can provide, because all these drugs are relatively young, are, as Natalie was saying, the long-term outcome of all these drugs. But so far, all these drugs have proved to be efficacious over time, and there is no loss of what has been achieved after the administration. Very good, thank you. This is a 3-year-old child. Is a boy who has been genetically identified with SMA5Q and who has 3 copies of the SMN2 gene. The child is walking, but he keeps falling, and he finds difficult to get up from the floor, and is also getting tired standing without support. So he's an ambulant child, but he's definitely showing signs of weakness and of progressive weakness, because he has increasing difficulties in getting up and in feeling tired. So the questions for this case are, again, which are the treatment options that are available for a child of 3 years and who is ambulant? And also, what other information should we need to discuss with the parents or the carers at the time of the treatment decision-making process?
Well, so if I can start. So for this patient, 3 years old, probably the weight will be too high to consider gene therapy. But the other 2 options, like nusinersen and risdiplam, are available for this child, and one of those should be administered anyway to limit the damage to the motor neurons. I think, yeah, the key factors to influence the choice between the options are also what we have discussed previously about side effects and type of route of administration, like giving intrathecal bolus injections is not easy in a 3-year-old little child. The child might be a bit more, how can I say, the oral intake might be easier for these little boys, but both could be considered.
Yes, I clearly agree that risdiplam or nusinersen should be considered here first, and especially for nusinersen, we have this patient is more in the clinical from a clinical phenotype that has been examined in the CHERISH trial, which is a little bit different to the patient population that has been examined in Sunfish, where mainly non-ambulant patients were the focus, especially of the part two. And I think it's important to emphasize that time is also here motor neuron, but not in the same not with the same rate of progression like in the first patient. But I think it's important to emphasize that the treatment goal or the treatment idea is to avoid the patient being wheelchair dependent. And I think it's maybe a realistic goal that should be also in the focus. And nonetheless, trying one drug first does not necessarily mean that we cannot switch in the long run to another drug if we see that possibly whatever that the drug is not efficient enough or is beside the expectation of the patient or beside our own expectations.
And I think for this case, we have to be a bit more cautious than for the first case, because in the first case, we had many papers or information regarding both safety and efficacy. And as you said, these children were not part of the pivotal studies, so we can only rely on real-world data, mainly for nusinersen, because risdiplam has become available only recently. And as you said, the patients with this level of functional ability, ambulant patients, were not included in the phase 2 of the pivotal study with risdiplam. So there is a rationale for thinking that the drug will work as is working in the others, but we have less evidence for both drugs than we have for both adults and younger children. So this brings us to the last question. What are the possible risks or benefits of the potential treatment options for this case? How would you put the risk benefits balance for this case?
Well, I think, as mentioned, we are quite happy with the safety of those drugs. I think the safety that we have so far are reassuring when we discuss to the parents the long-term treatment, because obviously this is a lifelong treatment. And I think about the efficacy, that this has also been mentioned, what patients may expect. We can go to real world data. We have less data from clinical trials. But again, from our own experience, I think we can be positive to the parents that at least we will slow down the disease, and obviously and hopefully we will keep indeed the ambulatory function of these patients. Saying this, I think that all these patients should be be included in long-term data collection to improve our insights on both the efficacy and the safety of those new drugs. And the more we get those data, the better we are in a place to discuss these aspects with the parents about expectations and safety.
Yes, I think one important point that we haven't mentioned is that how important is to have expectation put in context with the natural history. We, as clinicians, we know that a child is a 3-year-old and he's already showing difficulties, falling over frequently and getting up from the floor, is very likely to be in the group of type 3 who he's at high risk of losing ambulation, or at least this what was happening before this treatment. So in this particular case, because we know that the risk that this child will lose ambulation even by the age of 5 or 8, or when he's a teenager as the best option, makes us think, as you both were saying, that keeping ambulation would be a huge achievement for this child. So we do not expect improvements as we have seen in other subgroups of patients treated who had a more stable phase. But in this child in whom we can foresee a deterioration, stability, and maintaining ambulation would be a very important goal to achieve. So this is very important to discuss with families and to set up the right expectations. We now move to the oldest of the three patients. This is an adult patient, is a young adult, age 18 years, and she's complaining of extreme fatigue when doing anything physical. She has had a number of falls recently and is thinking about using a stick to help prevent the falls. She had a diagnosis of SMA, of 5q SMA, with 4 copies of SMN2. So the questions here are, in an adult who is ambulant but who is showing signs of weakness and some deterioration because she is considering using a stick because of the increased number of falls, what are the treatment options that we would consider for this particular patient? And specifically, as we have done for the other cases, what sort of information what we want to find out from her, trying to understand what is the severity and the progression of the disease in order to arrive to a treatment decision. Tim, do you want to take this over?
Yes, thank you. I think what is similar to the case we saw before is that the gene replacement therapy with onasemnogene is not an option here. There is no data for that. The patient is too old and of too high body weight. But so we have to think about risdiplam or nusinersen, and I think it's important to emphasize that this subpopulation, ambulatory type 3 patients, haven't been examined in the pivotal studies. Not in the studies on nusinersen and not in the studies on risdiplam. Especially in risdiplam, adult patients were in the sunfish trial, but only non-ambulatory patients. So we have to focus on real evidence here when thinking about treatment option. And I think this is one patient that can benefit from the real world evidence we have so far, because when we look into the data of that real world evidence, we see that especially adult ambulatory patients have the most beneficial effects. For example, with nusinersen within the broad heterogeneity of the adult patients. But on the other hand, there are some key factors that have also to be considered, like in which situation the patient is. This is a young patient, so possibly he is thinking about starting study at university or starting a job. So the treatment has to fit in the patient's personal situation. So is it possible to come to a treatment center? How long is the distance to the next treatment center? How does that fit into the patient's personal situation? I think these are the considerations we have to share here, especially with the patient. Yeah.
Yes, and very often adults who have some signs of the disease but who are not severely affected are also not very prone to go for more invasive treatments. This is not always the case, and this particular case may already be quite severely affected if she's considered sick. But in other cases, we have had a few adults who have refused to be treated with nusinersen at the time when this was the only available option, and who are now coming back at the time when an oral product is available. This of course doesn't apply to all. It's limited to a number of patients, but I think it's, as you said, it's very important to take into considerations a number of options that are available in relation to what the patient feels. And with adults, we have a number of patients who are not regularly followed in tertiary care centers, and I think the advent of the new, the arrival of the new therapies has produced that we are now seeing more adults than before, because many of them are curious, at least to get information about these new available treatments.
Yeah, and I think if I may add something for this case, we have a specific aspects also to discuss. Is this young lady might want to get pregnant at some stage, and we do not have data. For instance, if we prescribe risdiplam about the toxicity to the fetus. So I think this again is something we should consider in our discussion about the risk of taking risdiplam. Versus nusinersen in the context of childbearing age.
That's a fair point. This brings us to the overall evaluation of the potential risk versus benefits of the two different options that we have for this patient. How would you grade this on the basis of what is available from the literature and from your experience?
Yes, I think as we observe it so far in the data we have from the literature that nusinersen as well as risdiplam is safe. But for nusinersen, we have more clinical experience and more, in addition, safety data. We have long-term follow-ups looking at lab results in these patients, and we don't find a significant increase, for example, with cases of thrombocytopenia or renal damage. I think it's possibly more a class effect of systemically administered ASOs that we found within the intrathecal injection. And for risdiplam, well, we have the data that it is also safe from retinal or ophthalmological aspects. This is also data that is coming from the pivotal studies. But as Natalie already mentioned, a pregnancy or possible pregnancy has to be considered in such cases because there is the data with a possibly transient reduction of male fertility on the one hand, and on the other hand, the fetotoxic effects during pregnancy when we think about treatment of female patients.
And if we discuss the treatment, possible treatment outcomes, I think for this girl, as we have discussed in the other boy, as you were saying, Tim, at the beginning, I think a realistic expectations is to slow down the progression of the disease. There are enough studies using nusinersen in adults showing that we may see an improvement in the 6-minute walk test, but even slowing down the progression of the disease and maintaining ambulation, reducing the number of falls, or not having an increase of the number of falls would be a realistic, successful expectation as a possible response.
And I think treatment time is also important to emphasize here. So I think a minimum treatment time in such a long-standing disease should be minimum a year or possibly younger before we can really judge on the efficacy. And this is something that has also to be considered when thinking about management of treatment expectation. That patients shouldn't expect too much too early. So a year or minimum should be, yes, the patient should have information about that.
Yes, I think this is an important point, especially in patients who have a slow progression compared to type 1, because they may have had sometimes during their life when they have been stable for a year or even longer. But I think what we are now seeing, now that drugs have been available for a few years, is that the stability over many years is something that is not something we were used to see consistently before the advent of therapy. So your point is a very good one, that the best results probably will be seen with increasing time on therapy, because even maintaining a stable pattern of weakness over several years is a great success. And this brings us to the conclusions. The conclusions are that we are very lucky to have different treatment options. In many other disorders, neuromuscular disorders, we don't have the luxury to have treatments at all. So here we have 3 treatment options. And I think one important point that came across all 3 cases was that it's very important to manage expectations depending on the natural history of the disease. on that particular person who is going to be treated. So, of course, expectations are different, type 1, type 2, and type 3. And it's always important to think of what would happen to this person in the absence of a treatment. And we know this from the natural history. So it's important to manage expectations. Safety is not a major concern, but of course, there are some considerations to be made at the time of discussing this with the families, because there may be relatively common and non-severe side effects at the time of dosing, and there may be other that may come up. They are relatively rare, but it's important that the patients or the families get all this information. So I think the overall comment is that in all three cases, we see the possibility of improving, of having a new natural history, of improving what these patients are showing, and I think the overall balance is positive for all three. So this is the end of our session. Thank you for watching these case-based discussions of consideration for the selection of disease-modifying treatments in SMA, and we really hope it has been useful for you. I would like to thank again Tim and Natalie for sharing with me the opportunity to discuss this with you, and thank you everyone.